All right, I'm going to share my screen. Okay. And I'm going to summarize the conduction abnormalities. Okay. The last time we started to discuss the arrhythmias, and we called arrhythmias that everything else that is not a normal sinus rhythm. And what we specify what the normal sinus rhythm is, basically is rhythmic. The PP intervals is normal. The RR interval is normal. Every P followed by QRS, the PR interval is normal. And the P is originated from the SA node. This is the no, and the rate is between 60 to 100. That's the normal sinus rhythm. And the first we started that we can have arrhythmias when we have an abnormality of the impulse formation. What does it mean? We can have an arrhythmically generated impulse that it doesn't come in time, or it's coming faster or coming slower, or it's not originated from the SA node. So this is why we do have, let's see, as the disorders or impulse formation, such as the heterotopic when it's not from the sinus, and the nomotopic that is going through the sinus, but we have different type of arrhythmias. Now, the next session that we starting today's, or you already watched these videos, when we do have a completely normally formed impulse, that the impulse is formed in the SA node and it comes rhythmically. So everything good with the impulse formation, but that impulse that is formed is not propagated normally to another area of the heart. And this is what is called conduction abnormalities. There are two big portions of the conduction abnormalities. When we do have a slow conduction, or we do have a block of the conduction, or we do have a faster conduction, and this is what is called pre-excitation syndromes. But let's first, stick to the conduction abnormalities when we do have a slow conduction, or what is called a block. Now, depending on the severity of the block, we grading this severity. The less severe is called grade 1, and the most one is grade 3. What does it mean? Grade 1 means that every impulse that generated gets to another area, but slower. So it's meaning that slowing the conduction. Grade 2 means that the conduction is worsening because there are some unconducted bits. And grade 3, the severe one, there's no connection between these two areas of the heart. This is the 3rd degree block that we have. Depending on the location of this block, anywhere inside the heart where we have some kind of classical connected areas, such as the SA and the atrium, that's the SA block. Between the atrium and the ventricle, that's called the AV block. And we do have the intraventricular blocks. So these are the different types of the conduction abnormalities. Now, when we talk about conduction, we always evaluating the connection between 2 points. I named it A and B. So A is the starting point for the conduction, and this kind of charge gets from A to B. Normally, we do have a certain velocity how the charge gets to A to B, so we have a certain time period when the charge should get from one area to another area. That's a normal. Now, what do we call as a 1st degree block? 1st degree block means that we do have a connection between A and B, and every impulse that is originated in A is getting to B. However, this is slower, so it takes longer time to get one point to another one. So if we had, for example, a connection that the speed was, for example, 1 millimeter per second in a normal case, now we do have, for example, 2 or 3 or 4 millimeter or less, half millimeter per second. So about 50% the speed, but every charge gets through from A to B without any problem. So that's be rhythmic because this conduction always the same, but slower. So it won't cause any arrhythmia because every charge gets from A to B. Now, sorry, what do we call as a second degree block? Second degree block calls that we do have a good connection between A and B. So mostly the charge that's raised in A gets to B. However, there are some unconducted bits. So mostly conducted. So there are more connection than unconduction. So this means second degree. Very important that between two conducted bits, we cannot have more than only one unconducted. If you have more than one unconducted, that's be the high degree block. So that's meaning that only one unconducted bit can be between two conducted one. Now, this be a rhythmic one, because when we have conduction, that can generate, let's say, the ventricular conduction. When we do not have any connection, that we don't have ventricular contraction, so that's be arrhythmic. Depending on the severity of the second degree blocks and the type of this block, we have Mobitz type 1, Mobitz type 2. Mobitz type means that the speed of conduction is gradually worsening, and after we have a drop bit, and again start from the beginning. So it looks like the cycling back and forth. So the conduction is worsening, and after dropping, it's a little rest, and after coming again, normal, slowing, dropped. So this is how it works. So it meaning that we do have a slow conduction, slowing down the conduction. After no conduction, again start from the beginning. So it is faster, slower, no conduction. Faster, slower, no conduction. This is repeatedly coming, and this is called second degree Mobitz type 1. This no, it's Mobitz 2, Mobitz type 1 block or Wenke-Bach periodicity. There is another type when we have Mobitz type 2 block. Mobitz type 2 block means that we do have a constant speed. So whenever the conduction goes through, the speed the same, it won't slow down, or that doesn't change the conduction, but we do have some unconducted bits. This is what we do have. Okay, that's clear. Now, 2-to-1 blocks. 2-to-1 blocks means that it can have that one conducted, not conducted, one conducted, not conducted, one conducted, not conducted. Now, the problem is this is a second degree, still second degree, because between two conducted, we have only one unconducted one, and it can be Mobitz type 1, Mobitz type 2. We cannot differentiate using this 12-lead ECG, but the clinician always put a pacemaker into this heart, so they don't worry too much about it, about this 2-to-1 block, but we do have a separate entity for this kind of block. We do have a high degree blocks. High degree blocks means we do have much more unconducted bits than conducted one. So how can the patient survive this situation when they do have mostly unconduction between two areas? We have to have a lower pacemaker center, and escape rhythm is going to save the life of the patient. So as you see here, no conduction, no conduction, no conduction, some conduction, no conduction. So only one possibility is that some kind of lower center is going to hit, or especially in this area, depending on what grade this unconduction we have. And the worst one, when we have no connection between A and B at all, and for sure, all the time, we do have escape rhythm, a lower center is going to fire. Now, this kind of conduction abnormalities can be anywhere inside the heart, as I mentioned, can be between the SA and the atrium, that's an SA block, or can be between the atrium and the ventricle, this is an AV block, and can be intraventrically inside the ventricle. Okay, the best one to start with the AV blocks. Why? Because we do have the A point, such as atrial activation. we do have a B point, such as the ventricle activation, and we are evaluating the connection between the atrial activity and the ventricle activity. So you can see both when we have the A, when we have the B. No doubt about it, it's very nicely can be seen. Now, another problem with the assay block, that in assay block, we don't have this connect because what it says, there is no sign of A. We don't see on ECG when the sinus node is activated. What we do see on ECG, that's the atrial activation. So we do see only the P wave. There is no sign of the sinus activity. If you have an esophageal ECG, yes, you could see the sign when the assay is activated, or when you do have, for example, an intracardial ECG, yes, you can see it. But in the normal 12-lead ECG, you cannot see it. This is why it's more difficult to understand and difficult to diagnose. Intraventricular conduction abnormalities, we do have bundle branches inside, right and the left one, and this can be blocked. And of course, we do have the A and B located inside the ventricle. So what it has, widening of the QRS, and the morphology of the QRS is altered. So only the QRS should be evaluated when we want to see any kind of ventricle, intraventricular conduction abnormality. Now, let's start with the AV blocks. Okay, the AV blocks. AV blocks incomplete when we have third degree, second degree, and high degree. This is the incomplete, and the third degree is a complete one. Let's start with the first degree one. What the first degree means? The first degree means that we do have every P followed by QRS complex, but the PR interval is longer. Okay, so what we do see that rhythmic, the heart beats rhythmically. Every P is originated in the same area, okay, in the same time, in the same area, but the PR is getting longer. When the PR is getting longer, but because the velocity is the same, this is why it's rhythmic. So what we have to look at, from the beginning of the P to the beginning of the QRS, this PR interval is elongated. This is what, but every P followed by QRS, so that's be rhythmic. And you can say that is over 0.2 seconds. Now, the PR interval is not constant. The PR interval depends on the heart rate. If you have faster heart rate, your PR is shorter. If you have slower heart rate, the PR is longer. If you are younger, the PR is shorter. If you are elderly one, the PR is getting longer, but never ever be longer than 0.2 seconds. This is what you can remember, okay? Now, this is how it looks like. Rhythmic, yes. Heart rate, 1, 2, 3, 4, 4.5, for example. It's about 60, 65 or 70, that's okay. Do we have P wave? Yes, we do have P wave, and the P comes rhythmically, but the PR interval is longer than 0.2 seconds. This is 0.2 seconds. So this is why that's a first degree AV block. Good. This is very similarly, this picture, I think we do have this picture in the case studies as well. Okay. Second degree AV block, what we said, this is when the P wave comes regularly, but some P is not followed by QRS. And it looks like the RR intervals won't be the same. For sure, when the P is not followed by QRS, it won't be the same. There are two types, Mobitz type 1, Mobitz type 2. Let's look at first Mobitz type 1. When we have Mobitz type 1, it's meaning that the impulse conduction through the AV junction is worsening. So it's getting longer, longer, longer. Once is not conducted, the P is not followed by QRS. So when you look at the PR interval, is getting longer, 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 not conducted, start from the beginning, normal, longer, longer, not conducted. So this is one thing. And that's very easy. But the P intervals are constant. But here, there is a drop. It is not followed by QRS. So that is for sure is arrhythmic one. That's very easy to understand Mobitz type 1 or diagnose Mobitz type 1 because you see the PPP. You can put a paper and mark it where your PPs are. And after, when you see that, this is a not conducted P wave, look at the last one and compare the last PR to the first PR. And when you do see the last one is longer than the first one, that's Mobitz type 1. Now, another thing that we have to look at, the RR interval, is not, you don't need it for diagnosing AV block, Mobitz type 1. But it's good to understand because if you want to diagnose SA block, only one thing is left, the P waves and the changes of the PP interval. That can be a clue, whatever is a Mobitz type 1 or Mobitz type 2 SA block. We will get on later on a little bit. If you look at the RRs here, it looks like a little bit getting shorter. And I will explain you later why. So this is the Mobitz type 1 block. P, P, P coming regularly, but this P is not followed by QRS. The RR intervals getting shorter. And when you do have these drop Ps, these RRs is less than twice as the last RR. This is what Mobitz type 1 block means. So, diagnosing last conducted PR longer than the first conducted PR. Plus, you can use that this interval when the drop P has is less than twice as the last RR interval.
Can I ask a question?
Yes.
So this is a sinus rhythm? Or
yes.
Not because there is no.
It's a sinus. That's a sinus rhythm.
Even though we don't have a QRS after the P.
Yes, but this is not a normal sinus rhythm. Sinus rhythm only means that the sinus generates the impulse and activates the atrium.
So it's a sinus rhythm, but it's a normal one.
Yes. Yes.
Okay.
Yes. Yes. Now, so this is the explanation. If you go through and look through the whatever the written stuff that you can download from the YouTube, you will understand that these PRR intervals are getting a little bit shorter because this elongation relatively, it's, as you see here, the PR elongation somehow is shortening the TP interval here and less, and this is why the RR interval is getting shorter. Simple. Arrhythmic? Yes, it's arrhythmic. When we do have an arrhythmia, how do we calculate the heart rate? We count a longer interval, meaning 1 second, 2 seconds, 3 seconds, 4 seconds, 5 seconds, 6 seconds. How many are we have? 1, 2, 3, 4, 5, 6. So the rate is 60 per minute. Okay. Do we have P wave? Yeah, we do. The PP intervals are constant. This P is not followed by QRS. Let's look at the last conducted PR and compare to the first one. This is longer than this one, so this is why it's Mobitz type 1, second degree AV block. Axis, 1 is positive, AVF is equiphasic, okay. AVF is 90, perpendicular is lead number 1, it's 0 degrees, so it's the horizontal axis. Fine. Next one, Mobitz type 2. Mobitz type 2 means that's a distal one. So it's meaning that why Mobitz type 1 include the AV node as a proximal block, mostly reversible block. So it's very low the chance that develop the patient a third degree AV block. However, in Mobitz type 2, yes, there's a ischemic changes and usually progress to third degree AV block, and only the ventricle escape rhythm can save the life of the patient. So that's with a very low cardiac output. This is why they put a pacemaker. This is why it's important to distinguish Mobitz type 2 and Mobitz type 1. What it says, PP comes regularly, but we do see a P that's not followed by QRS complex. If you look at every P followed by QRS, except here, if you compare this distance, these are exactly twice as the last RR. This is how you can distinguish compared to the last PR to the first one, they equal There's no changes, and the RR intervals is the same, and this drop one twice as much as the last one. This is how you recognize it. 2 to 1, we have rhythmically coming P's, and every second P is dropped or every second B is conducted. This is how you can see very slow the heart rate because half as a normal one. So we do have a sinus written. If you look at the rate of the sinus, is about 1, 2, 3, 4, 75. Why the ventricle half the 75, 30, for example, the exit 32 that we do have here. That's simple. Here as well. Okay. Look at the high degree, what it means. Mostly unconducted, but sometimes conducted. Okay, when it's mostly unconducted, what does it mean? If it's not conducted, not conducted, not conducted, only the ventricle escape rhythm can save the life of the patient. So we do have a ventricle escape rhythm. Whenever the impulse goes through, we do have a P followed by QRS complex. So here, and this QRS be narrow, it looks like a supraventricular bit. So that is called the capture bit. But and this is not in time, so that makes it arrhythmic. So the high degree AV block is arrhythmic. When we do have an escape rhythm, that's rhythmic. But when we have a capture bit, that makes it arrhythmic. Now, there's a chance that the ventricle is sometimes activated simultaneously from the escape center and the supraventricular conduction. And this is why we do have a fusion bit. So it means that from the atrium, the charge comes, plus from the ectopic center, and both activates the same time the ventricle. For sure, this comes in time. So the RR as an escape rhythm will be the same as a RR fusion. But the RR capture is different from the RR or an RR fusion. This is how you can distinguish between these two. So we do have 3 types of morphology of the QRS complex. We do have one, the ventricle escape. We do have a fusion, and we do have a supraventricular picture bit. Okay, this is what we have. Okay, 3rd degree block, meaning there is no connection between the P wave and the QRS complex. How can we see it? If you find a PP interval, you can mark a paper and shift it, and you will see some P's that inside the QRS or inside the T or inside the ST segment. And if you have a ventricle rhythm, that's be easy because the QRS is wide, the T is inverted. But if you have a junctional one, only what you see, narrow QRS, positive T wave, but you do see some P's inside the QRSs. This is how you see that there's no connection between P and QRS. One thing, very easy one, if you count the rate of the P, is not proportional to the rate of the QRS complexes. And this is new, that there's no connection between the P and the QRS complexes. So 3rd degree block associate usually with an escape rhythm with a lower center. And this is what is called AV dissociation. Okay, this is very nicely. You can see that we do have a zillions of P waves, for example, and the QRS is very slow one. And look at the PR distance. The PR distance is changing, and there is no longer, and not conducted, but sometimes short one, sometimes and longer, getting longer. So it's not connected at all. And if you count the rate of the PPP, it won't be proportional to the rate of the ventricle rate. Okay, this is 3rd. That's a ventricle rhythm, what we have here. Okay. Now, let's go to the SA blocks. The SA blocks means that we do have an SA node that generates the impulse. However, the surrounding area, it doesn't let the charge goes through. So this way, the atrium, when we have a 3rd degree, is not activated at all. So it's meaning there is no P wave. This is what we are talking about, the 3rd degree. However, when we do have a 1st degree, it's meaning that the charge goes through to insulated area, but slower. So every impulse generated by the ST generates a P wave. So we cannot diagnose based on this normal 12-lead ECG. Not at all, because what we see only the P wave, nothing else. So if you had an esophageal ECG, you can compare the sinus activation and the time between sinus activation and the P wave. But using 12-lead ECG, no. So this is out. Second degree, now that's a problem because we don't see the sign of an SA. We do see the sign only when the atrium is activated. So looks like when we do have an AV, only we have the QRS complex. So we have to evaluate the PPPs. When we have a block, there is no P. Okay, there's no P at all. Now, how can we distinguish whether it's Mobitz type 1 or Mobitz type 2? Let's look at the P's, okay? Now, for example, let's start here. Sinus is starting, and after you have the atrial activation, and this is the conduction. As you see here, it's getting longer, longer, longer. And when we have no connection, when we have a drop one, as you see here, these PP interval, when we have the drop P's, it's relatively shorter than twice as this one. This is how you diagnose a first degree SA block Mobitz type 1. Okay, so the P is missing. In AV block, P was present, but there is no QRS. Here, no P wave, and this is why it's no QRS. So let's look at, this is a normal one, and that's the SA block. Relatively, P, there's no P, okay, PP, and look at this PP last, that's B, taking twice less B as this is here to twice the distance. Okay, so it's very similar to the RR. So this distance B a little bit shorter than this distance. That only means the Mobitz type 1, SA block, no P wave, no P wave. Mobitz type 2, exactly the same as the twice as the PP interval. That's it.
So I have a question.
Yes.
If I want to differentiate between SA block Mobitz 1, for example, and AV block Mobitz 1, so I'm looking for a P wave. And if I have a P wave, so it's AV, but no QRS, so it's AV. And if I don't have P wave and no QRS, so it's SA block.
Yes, correct.
Okay. Thank you.
Correct, correct. For example, here, what we have here, relatively, well, that's a T wave, it's not a P wave. Here, there is no P wave at all. We do have PPP. And if you can't, let's see the P's, for example, you can see the PPP is no P. And when you take twice as, this will be shorter one. This is how you know that SA block, Mobitz type 1. Mobitz type 2, again, PP, no P, no QRS, and twice as exactly and this distance. So that's distance taking twice, that's be the same. This is why SA block Mobitz type 2. Okay, simple. Now, we got into the ventricle. In the ventricle, we do have branches, bundle branches. We do have a right side as a right bundle branch, and on the left side, we do have an anterior fascicle, the septal, and the posterior fascicle branches. Now, these branches can be blocked, and if we block the branches, relatively that area of the ventricle activated slower from the other part, whatever is activated normally. This is how we distinguish right bundle branch block and left bundle branch block, and we can distinguish an anterior hemiblock, such as the anterior fascicle conduction abnormality or the posterior fascicle abnormality. This is how we can have. There are some bifascicular blocks, such as when we have a right bundle branch block and one of them, a hemiblock, is missing. These are the bifascicular block. And if you do have a bifascicular block plus an AV block, these are called the trifascicular blocks. This is how we can distinguish. And of course, usually these blocks is due to ischemia or myocardial MI. Let's revise what the normal ventricle activation looks like. First, the septum is activated. The septum activated from the left bundle, about 90% of the cases from the left bundles. And this is why In V1, we do have a positive deflection, and in V6, we have a negative one. And after the ventricle activation, right and left simultaneously, left is thicker, electric activity higher. This is why we do have a positivity on the left side and negativity in the right side. So here we have an RS, here we have a QR complex. Now, you learn in physiology that the ventricle activation time or the intrinsic deflection is from the beginning of the QRS complex till the last R wave, and that's different on the right side and the left side. On the right side, that's be about less than 0.0 second, and the left side is less than 0.06 second. So that's be different because that's far further from the ventricle activation. That's the normal situation. If we have a block on the right side, the ventricle activation time be longer on the right side. If we have a problem on the left side, that ventricle activation be longer on the left side and doesn't change on the right side. Let's look at right bundle branch block. Septal activation, normal. There is no changes at the beginning. Ventricle activation, left side activated normally, normal. However, right ventricle can be activated only from the left side, meaning that, again, we do have an R wave in V1 because the activation goes toward the V1. So this is an RSR complex. And as you see here, the last part of the QRS is elongated. And we do have a negative wide S wave on the left side. So that's, again, a wide S wave on the left side. If you look at the ID time, is elongated on the right side, doesn't change on the left side. This is how you know that that's a right bundle branch block. But you're always looking in V1, the RSR complex and the wide S wave on the left side. Okay, good. Let's.
Professor?
Yes?
Can you explain about why in the V1 R is started and in the V6 Q is started?
Which one that you're talking about?
Yeah, here. Yeah.
Okay.
In the V1 R is started first.
Because that's the septal activation. The septum is activated from the left bundle. The left bundle is intact. And this goes from left to the right. This is why you do have a positivity in V1 and negativity in V6, because it goes away from the left, goes toward the right.
So it is only related to the direction of the vector?
Yes, that's it. That's it.
Okay.
Exactly. And the next one, when the ventricle is activated, but left one activated. So it goes from the right to the left, because the left side is activated. This is why you have a negativity in V1 and positivity in V6 or left side. And when you do have, again, an activation of the right side, it goes from the left to the right. And this is why you have a positivity in V1 and negativity in V6. Yes?
Okay, I got it.
Okay, good. Let's move on. Here, very similarly, this is what you decided. Okay, this rhythmic, fine. The rate is around 70, maybe a little bit more, 80. Okay, we have P wave. Yes, we do have a regularly coming P wave. PR is normal, X is, but it's about normal. AVF, it's about normal, but 90 degrees or so, very close to 90 degrees because that looks like ectophysic. Okay, QRS is wide. Yes, it's wide. It's very important because it's meaning that the intraventricular activation takes longer time. Okay, good. Have to look at V1 and V6. Where do you see this R complex? V1. So right bundle branch block. That's it. Okay. Now, incomplete and complete. Doesn't matter both showing the same kind of characteristic sign, so the M complex or the S wave, but the duration of the QRS, if it's less than 12, that means incomplete. If it's more than 12, complete. That's it. Nothing else. I'm sorry. Let's see the left bundle branch block. Left bundle branch block, we have a problem with the septal activation because the septal bunch is missing. So only this area can be activated from the right. So we have a vector that goes from right to the left. This is why, okay, what we have. We do have a negativity starting in V1 and positivity in V6 because the vector pointing toward the left side. After which ventricle is activated? The right one, because the bundle is there. Again, we do have a little positivity here, but because the left is starting right away with the septum, we do have a more negativity and we do have a positivity in V6. So as you see here, you can look at what's happening. Here we have a QS complex or W, and here we have an M complex in V6, where the ID time is elongated on the left side. So you know that the ventricle activation takes longer on the left side. So if you want to find the wide R complex, is located on the left side. Okay, good. All right, this is how it looks like. Rhythmic, fine. Now here, PR interval, it's okay. It's about the borderline. Axis, one positive, negative. It's about 0 to -30 because that's a little bit positive. QRS is wide. Yes, where do we see this wide R wave? It's V6 on the left side and lead number 1 and QS complex in V1. So that's a complete left bundle branch block. Good. Now, because the left bundle composed of two branches, the anterior fascicles and the posterior fascicles, and both separately can be blocked, we can have an anterior fascicle conduction abnormalities or a posterior fascicle and conduction abnormalities. Very simple. The duration of the QRS is not altered, only the axis be altered. Now, if you put your arm some here, if you grab your child, for example, that's an infant one. Usually the head is close to your heart, okay? So your left arm is above and the right one below. And this is the normal activation. If the anterior is missing, that's an anterior when your left arm is missing. So only from the posterior can be activated this area. So you have a pathologic left deviation. If the posterior fascicle is missing, you have a pathological right deviation. So it goes toward the right side. This is how you can distinguish. So the method of the axis, this is how you diagnose the hemiblocks. Rhythmic, sinus, rate, 1, 2, 3, 4. It's about, let's see, for example, 65, good, P wave, yes, PR, normal, QRS, well, it's a borderline 0.1 second, good, axis 1 positive, AVF negative, lead number 2 negative, extreme left deviation. So that's a left anterior hemiblock. It's not rhythmic right here. We do have a, as you see here, right away, you can see we do have an atrial premature contraction here, right here. Because we have a P wave here. We don't see the P wave right here, but here I do see the P wave. Okay, good. Posterior, the opposite. When the axis exactly on the other side, we do have an extreme right deviation. Yes, rhythmic, yeah, rate is around 100. P wave, yes, sinus tachycardia, okay. PR is okay, normal. Axis, negative. AVR is negative. But you can say that's an extreme right deviation. Good. QRS is narrow. Okay, what thing you can diagnose? That's a posterior hemiblock. That's it. Now, bifascicular blocks, as I mentioned, when we have a right bundle branch block, the typical sign of a right bundle branch block, such as an M complex in V1 and a deep SV1 lead number 1 or 6, okay, somewhere here, yes. And we do have an axis deviation, an extreme left deviation, 1 positive, 2 negative, that's an anterior hemiblock, or we can have the opposite one when we have a posterior hemiblock, when we do have a, but this is not a posterior hemiblock for sure, because that's an anterior, so it's normal, that's an axis is completely normal, that's picture is not normal, I think it's not normal, I think there's the old version of the PPT5. Okay. Now, trifascicular block. What the trifascicular block means? Trifascicular block means that do have a bifascicular block, right bundle branch block, and a hemiblock. Plus, we do have a first degree AV block. So the PR interval is elongated. Or we do have a left bundle branch block and the first degree AV block. That's again a trifascicular block. Okay, good, that's it. Go on. This block can be rate dependent. If the rate increases, less time for repolarization, and it's meaning that this is not a complete third degree block, that's a high degree block. When above a certain rate, you see the right bundle branch block, and below a rate, you don't see the right bundle branch block. So this is the frequency depending intraventricular conduction abnormalities. So far, we had those things when we had a slower conduction. We can have faster conduction, and this is what is called pre-excitation syndrome. Usually, we have an accessory bundles, such as between the atrium and the ventricle, that's a bundle of Kent, or between the atrium and this goes, the James fiber goes to the bundle of His. So these are the WPW syndrome, and that's the LGS syndrome. Okay. Most common one, the WPW syndrome. Usually we do have a bundle of Kent that connecting the atrial muscle to the ventricular muscle. What is the problem? The problem is that when we have the charge in the atrium, it activates the atrium, fine. Reaching the AV node, okay. Reaching the bundle of Kent, fine. What will happen? After, when it's finishing the atrial activation, the bundle activation starting right away. And when the AV junctional delay reaching this activation, it will activate the left over part of the ventricle. So this is why the slow starting and fast ending QRS complex you see, and this is what is called the delta wave. That's a delta wave, okay? This is what we call delta wave. So the PR is short and the QR is wide. There are two types of this WPW syndrome, major types. The A, when in V1 we have a positivity, or B, when we have a negativity. It's depending on where this bundle of Kent is located. If it's located on the left side, we have an A. If it's located on the right side, that's a B type. That's it. Okay, that's an A type, as you see here, is starting positively. Okay, or it's a negative, that's a B type, and you do see this nice delta wave and short PR interval. LGS syndrome, PR is short, QRS is narrow, so it's nothing else. Only what you do see that P followed right away with the QRS complexes. That's it, nothing else.
Professor?
No. Yes?
For the Wolff-Parkinson-White syndrome, the P wave can be overlap with the QRS.
No.
No?
The P should be in front of the QRS complex. It's never inside the QRS complex, but it's close to the QRS complex. Okay, that's very important. If you look at this, immediately after the P, QRS starting. This is how you diagnose it. So never ever be the P inside the QRS complex. Okay. Now, because we do have two parallel pathways, that's a chance that we have a re-entry cycle. Because two parallel pathways with different refractor period, different refractor period or different velocity, that's a chance that we do have this re-entry cycle. Now, there are two possibilities. One possibility is when the ventricle activated through the normal conducting system and the bundle of Kent reuptakes the charge. This is one circle of the re-entry. Okay, but all the time the ventricle activated through the normal conducting system, so that's been narrow, but fast. And when we do have the opposite direction, bundle of Kent activates the ventricle, AV junction reuptakes the charge. We do have a wide QRS complex, tachycardic one, that's an antidromic, and orthodromic AV-RT tachycardias. These are the two types of both supraventricular but macro re-entry that we have. The patient can stop it by carotid massage, so altering the AV conduction, and that can cut, let's see, the circle, this re-entry circle, a cycle, and immediately that'd be normal. This is how it looks like. That's an antidromic, because it looks like it's a ventricular tachycardia, but you know that in the rest, the patient has a the delta wave, and the patient suffering of the WPW. So you can assume that this patient has not a ventricular tachycardia, but a WPW syndrome. And if the tachycardia can be seized by carotid massage, for sure is a supraventricular tachycardia. It's not a ventricle because ventricle cannot alter. Okay, orthodromic one, narrow QRS is, and of course at rest the patient has the delta wave. This is how you know that it's not a AV and RT tachycardia, because AV and RT tachycardia look the same. What is AV and RT tachycardia? When there is no accessory pathways, only inside the AV node we have this re-entry cycle, and narrow QRS that we detect. That's the most common cause of a supraventricular paroxysmal tachycardia. That's an AV-RT tachycardia, AV and RT tachycardia, identical. So at rest, the patient does not have any kind of delta wave, any kind of PR shortening. Okay,